Rahim. My name is Owais Ahmad. I am a T8 semester student of caste. Today my presentation topic is iron deficiency anemia. My presentation topic outline introduction of anemia, introduction of iron deficiency anemia, sources of iron, metabolism of iron, causes, stages of iron deficiency anemia, lab finding, diagnosis and treatment. What is anemia? Anemia is one of the most underdiagnosed conditions and, if left untreated, can have many serious implications such as cardiovascular disease and compromised immune function. According to WHO estimate, India is one of the countries in the world that has highest prevalence of anemia. Definition: anemia is a Greek word mean lack of bloods. Is a decrease in number of red blood cells are less than the normal quantity of hemoglobin in blood. Hemoglobin in men less than 13.5 gram per deciliter, and women hemoglobin level is less than 12 gram per deciliter. Iron deficiency anemia. What is iron? Iron is one of the most essential trace elements. Total body iron content in 3 to 5 gram, 75% in blood, the rest of in liver, bone marrow and muscles. Iron is present in almost all cells. Heme is the most predominant iron containing substance. Sources of iron. The best source of food iron include liver, meat, egg, yolk, green leafy vegetable and dates. In typical Indian diets, the major quantity of iron is received from Kerala because of the bulk quantity taken, although they contain iron only in moderate amount. Meat and seafood is a good source of iron. Milk is very poor source of iron, contain less than 0.1 milligram. RDA recommended dietary allowance. In adult men and post-menopausal women contain 10 milligram, and premenopausal women required 15 to 12 milligram. Pregnant women required 30 to 60 milligram. Women required greater amount than men due to physiological laws during menstruation. Biochemical function. Iron is a component of several functional important molecules. Iron is required for the synthesis of hemoglobin, myoglobin, cytochrome, catalase, and peroxidase. Iron is help mainly in transport, storage, and utilization of oxygen. Metabolism of iron. Iron is absorbed from upper small intestine. Iron is absorbed in three forms. First, ferrous iron. Second, ferric iron. Third is heme iron. Iron is absorbed mainly in ferrous form. Ferric iron are reduced with ascorbic acid and glutamine of food to more soluble ferrous, from which is more readily absorbed than ferric iron. After taken up by intestinal mucosa, iron is either stored in the form of ferritin in the mucosal cell or transported across the mucosal cell to plasma in the form of transferrin. The iron entering the mucosal cell by absorption is oxidized to ferric form by enzyme peroxidase. Ferric combine with apophyrin to form ferritin, which the temporary storage for iron. Causes of iron deficiency anemia: increased demand of iron, rapid growth in infancy or adolescence, pregnancy, erythropoietin therapy, increased iron loss, chronic blood loss condition, menses, acute blood loss, blood donation, decreased iron intake or absorption, inadequate diets, malabsorption from disease, malabsorption from surgery, acute or chronic inflammation. Stages of iron deficiency anemia. First is negative iron balance. Demand for iron exceeds the body ability to absorb iron from the diets. Blood loss, pregnancy, and rapid growth. Blood loss is excess of 10 to 20 milliliter of red cell per day is greater than the amount of iron that the gut can absorb from normal diets. The iron defect must be made up by mobilization of iron from RE storage site. At this stage, red cell morphology and induce are normal. Iron deficiency erythropoiesis. When iron storage becomes depleted, the serum iron begins to fall gradually, the TIBC increase. Once the transferrin saturation falls to 15 to 20%, hemoglobin synthesis becomes impaired. First appearance of macrocytic cells. Iron deficiency anemia. Hemoglobin and hematocrit begin to fall. The transferrin saturation at this point is 10 to 15 gram percent. Laboratory finding: serum iron or total iron binding capacity. Serum iron level represents the amount of circulating iron bound to transferrin. The TIBC is indirect measure of circulating transferrin. Normal value serum iron is 50 to 150 milligram per deciliter. The TIBC is 300 to 360 milligram per deciliter. Transferrin saturation: serum iron multiplied by 100 divided by TIBC. Normally 25 to 50%. Iron deficiency states are associated with saturation level below 20%. Serum ferritin: under steady state condition, the serum ferritin level correctly with total body iron store. Normal value of serum ferritin in adult male 100 microliter, in adult female 30 milligram per liter. Serum ferritin less than 15 milligram per liter are diagnostic of absent body iron store. Evolution of bone marrow iron store. Bone marrow aspirate or biopsies. The bone marrow iron stain provide information about the effective delivery of iron to developing erythroblast. Differential diagnosis: other than iron deficiency, Only three conditions needed to be considered in differential diagnosis of hypochromic and microcytic anemia: anemia of inflammation, thalassemia, sideroblastic anemia. Treatment: red cell transfusion, induction. Individuals who have symptoms of anemia, cardiovascular instability, continued and excessive blood loss from whatever source, who require immediate intervention. Oral iron therapy: ferrous sulfate, ferrous formate, ferrous gluconate, or oral iron therapy. Up to 20 milligrams of elemental iron per day is given. Usually is 3 or 4 iron tablets, each contain 50 to 65 milligram elemental iron given over the course of a day. Ideally, oral iron preparation should be taken on empty stomach since food may inhibit iron absorption. The goal of therapy is individually with iron deficiency anemia is not only to repair the anemia but also to provide store of at least 0.5 to 1 gram of iron. Sustained treatment for a period 6 to 12 months after correction of anemia will be necessary to achieve this. Side effect: gastrointestinal distress, abdominal pain, nausea, vomiting, or constipation. Parenteral oral therapy. Indication: patients who are unable to tolerate oral iron, whose needs are relatively acute, who need iron on an ongoing basis. Iron dextrine, sodium ferric glutamine, iron sucrose, and ferric carboxylate. Ferric glutamine deliver 125 mg per injection. Ferric carboxylate 750 mg per injection and iron sucrose 200 mg per injection. The amount of iron needed by individual patient is calculated by the following formula: body weight multiplied by 2.3 multiplied by 15 patient hemoglobin gram per deciliter plus 500 to 1000 milligram for store. Side effect: anaphylaxis, most commonly with iron dextrine. Earlier in the infusion of iron, if chest pain, a fall in blood pressure, or other systemic symptoms occur, the infusion of iron should be stopped immediately. Thank you.